Good morning. Welcome back to Open Med School. I am Dr. Andrews, Professor of Medicine, Consultant Neurologist. Today I'll be discussing CBME Competency Internal Medicine 1.12 Peripheral Pulse in Heart Failure. We know that pulse is a pressure wave transmitted across a vessel wall due to ejection of blood into already filled aorta. So remember, it is a pressure wave transmitted across the vessel wall. Let us just see the shape of the pulse. The pulse has got a percussion wave due to the ejection of blood, followed by a small bump on the ascending limb. This is the tidal wave. Tidal wave is due to the reflected waves from periphery. Then there is a dicrotic notch and a dicrotic wave. So you should be able to draw the pulse. So this is the percussion wave, this is the tidal wave, followed by the dicrotic notch and dicrotic wave. So this part, here comes the systole. So this is the systolic component and the rest is the diastole. So it is shown here. So this is the basic understanding regarding the pulse. The details of the pulse will be discussed in separate sessions. So by the end of the session, you will be able to identify the rate, rhythm, volume, character. That is a proper description of the pulse. Correlate the various abnormalities of the pulse in heart failure and some of the pulses in some specific heart diseases. Pulse examination is not merely counting, it is a clinical reasoning. So pulse is the most accessible expression of the heart. Before ECG and echo, the first information your fingers can give you about the heart is the pulse. That is the importance of the pulse. So how to examine the pulse? This will be demonstrated in a separate session, but just remember, you should use your 3 fingers. The hand should be semi-flexed, semi-prone, and it's always better to palpate both pulses initially, both radial pulses initially, then continue with the radial pulse on identifying the various features of pulse like rate, rhythm, volume, condition of the vessel wall. Remember, the character of the pulse is examined on a central vessel, except the collapsing nature of the pulse, which is done on the radial pulse. Hope this point is clear to you. Now we just go into some of the common abnormalities in the pulse. What will happen to the pulse in heart failure? When the heart fails, it is a sympathetic nervous system that comes to the support. So tachycardia, sinus tachycardia is common in heart failure. So this reflects a low stroke volume. When the low stroke volume, the sympathetic nervous system comes over the head. Persistent tachycardia signifies reduced heart cardiac output. Hope this point is clear to you. So sinus tachycardia can occur in heart failure or even before development of overt heart failure. For example, somebody is undergoing surgery, that is, a stroke volume is coming down, you can get a sympathetic activation. Then some of the abnormalities in the rhythm, you should remember, one is the irregular rhythm. Here you can see that the is irregular either instead of the ECG you will be seeing the fibrillatory waves. So the pulse will be, there is no regularity for the irregularity. So that is what is happening in atrial fibrillation. Atrial fibrillation worsens heart failure. What's the reason? So in the last 1/3 of the Ventricular filling is by atrial kick. So atrial kick produces filling in the last part. So this is lost. This leads on to dysfunction. So atrial fibrillation worsens heart failure due to loss of the atrial kick. Atrial fibrillation is both a cause and consequence of heart failure. AF can lead on to heart failure. At the same time, a heart failure can lead on to AF. So it is a cause and consequence. Patient with beta blocker or patient on digoxin, heart rate may be controlled and the atrial fibrillation may be missed unless examined for 1 minute. So first is rate, second is looking for the rhythm, third you look at the volume of the pulse. What is the volume of the pulse? The distance to which your fingers are lifted indicates the volume of the pulse. Pulse can be divided into high volume pulse and low volume pulse. Low volume pulse means it is low cardiac output. When the stroke volume is less, you get because the ventricle is not contracting properly, when there is a heart failure, the stroke volume is low. Naturally, the pulse volume will also be low. A bounding pulse occurs when there is a high output state, like anemia, thyrotoxicosis, beriberi. All these produces a bounding aortic regurgitation. So pulse, remember pulse volume. The volume of the pulse indicates the stroke volume. Hope this point is clear to you. So in a valvular disease, when you get a bounding pulse or a high volume pulse, first you remember aortic regurgitation. Or some hyperdynamic circulation like pregnancy, thyrotoxicosis, fever, all these can lead on to a little high volume pulse. So what are the high output cardiac failures? Already mentioned anemia, thyrotoxicosis, arteriovenous fistula. Sometimes you can get in Page's disease. Patient of the dialysis with AV fistula, again you can get a high volume pulse. So bounding pulse despite heart failure. These are the conditions. Hope this point is clear. Now going to the characters, as already mentioned, the important characters are described in the central pulse. 1 or 2 you describe in the peripheral. One is the pulsus alternans. So what is a pulsus alternans? Pulsus alternans is alternating pulses are large and small. So this is what is called pulsus alternans. So pulsus alternans is a regular pulse. It's not irregular pulse. Don't confuse with the pulses bigeminy. In pulses bigeminy, 2 pulses, 1 pulse followed by another pulse. 2 pulses are coupled together. One may be large, other will be small. This pulsus alternans is a feature of severe LV dysfunction. So when the heart fails, what happens? Stroke, the heart is unable to pump blood. So some amount of blood is remaining there, stagnating. So end diastolic volume is high. So next time when the heart contracts, the remaining blood and the blood that is coming to the heart both together produces a little more enlargement of the heart, or the stroke volume is high, or end diastolic volume is high. So Starling's forces or Starling's law, that is the contraction is related to initial length of the muscle. So here the length is the volume of the heart. So it will get a more forceful contraction. So the cycle repeats. So hope you understood what is the mechanism of the pulsus alternans. This is a grave sign of LV dysfunction. So pulsus alternans is a grave sign of. Now we are going to collapsing pulse. This is another pulse that you have character is examined in the periphery. So whenever you get a high volume pulse, you look whether it is a collapsing pulse. So what is a collapsing pulse? A collapsing pulse is a high volume pulse, rapid upstroke and a rapid downstroke. This is a characteristic which is it is sometimes called a water hammer pulse. Water hammer. Water hammer is a toy. So what are the conditions where you get the classical valvular disease is aortic regurgitation. We can get in congenital heart disease like patent ductus arteriosus. We can occur in arteriovenous fistula. So remember these three things. That is, collapsing pulse is a high volume pulse, rapid upstroke and rapid downstroke. Hope it is clear to you. Now you go for the slow rising pulse. So suppose there is aortic stenosis. What happens? Patient with a aortic stenosis, the ventricle has to strain to contract because the valve is narrow. So it takes time for the percussion wave becomes flat. So what happens? The pulse becomes a slow rising pulse. Stroke volume is also low. So what happens? The height is less. This sort of pulse is called pulsus parvus attardus. Parvus means the height is less, slow, small. Tardus means late. Tardive dyskinesia was studied. So aortic stenosis produces classically a slow rising pulse. It indicates a obstructed left ventricular outflow. Hope this point is clear to you. Now we think about the variations in the pulse. The variations of pulse we are mainly concerned with. One is the radio-radial delay, respiratory variation and pulsus paradoxus. Radio-radial delay is seen in coarctation of aorta. So what is happening in coarctation? So take this is the aorta. There is a narrowing of the aorta. So what happens? The pressure wave, there is a delay. The pressure wave passing through the arterial wall gets delayed after the coarcted part. So there is a significant delay between the radial artery and femoral artery. Sometimes you can get a radio-radial delay. There is one radial artery, the other radial artery, there can be delay if there is a problem with the subclavian stenosis is an example. Cervical rib you can get sometimes. Pulsus paradoxus, last time we have mentioned, pulsus paradox is it's not paradoxical, it is a exaggeration of what is normal. That is during inspiration, the pulse volume comes down. If you measure using a sphygmomanometer, if it is more than 10 millimeters, it is called pulsus paradoxus and it is classically seen in pericardial tamponade. Sometimes can be seen in severe COPD also. So we have discussed most of the features, then the remaining things are to palpate all the peripheral pulses, looking for the thickening of the vessels. Some of the patterns in heart failure also you look into. So in dilated cardiomyopathy you get a low volume pulse, we can get pulsus alternans. Aortic regurgitation you get a collapsing pulse. Aortic stenosis you get a slow rising pulse. Atrial fibrillation produces irregular pulse. These are fundamental things that you should remember. So now you go to the ward, use the correct technique. and describe the pulse the correct way and correlate with the clinical findings. Describe what you feel. So when you describe the pulse, you should say pulse is, if it is a normal pulse, you say pulse 72 per minute, regular in rhythm, normal volume and character, no radiofrequency delay, all peripheral pulses are palpable, vessel bond is just palpable. These are the components that you should say when you are describing pulse. Stay tuned for further videos. Thank you.